حيدر، احنا بدنا ننتظر، ممكن نعرف الحضور شنو هي اختصاصاتهم ما دام إحنا بدنا ننتظر.
دكتور، أطباء حديثين التخرج، يعني متخرجين حديثا أو طلاب طب.
اوكي
تمام، فهم ميديكال فيلد.
اوكي، اكو غيرهم يعني اختصاص له؟
حاليا لا، احنا الدعوات دزيناها فقط جماعة الميديكال فيلد.
اوكي
تمام.
So Alicia, we were just saying most of the attendants are either newly grad or, some of them are still in medical school, so we don't have any like trauma surgeons or anything like that.
This should be good for
Yeah,
anyone.
just so you have an idea about the audience. Okay, I think it's 3:05 for everybody. My name is Firas Karmo. I'm actually a graduate of University of Baghdad, 1988, and I'm a plastic surgeon here in the United States. I had contact with Zina and Haider in the group, and we've been in talk for about the last 2-3 months. And finally, this is the first of the series of lectures that hopefully will continue. The request was, for some, trauma and, what are the guidelines about, trauma, and I think an appropriate audience for the newly, grad and the medical students. Dr. Alicia Kieninger, a colleague of mine, and, we work together. She's a general surgeon. She finished her training in general surgeon, then she had a fellowship in both trauma and, critical care fellowship. She's been with us, Alicia, for how long now?
11 years.
11 years, and she's actually the director of our trauma unit. So she's going to tell us a bit about the, updates and the guidelines. And probably at the end, if there are any questions, I'm sure Dr. Kieninger will be more than happy to entertain. Alicia, it's yours.
Sure. Thanks for having me. Like Dr. Kerman said, I'm the trauma medical director here at St. Joe's, and I've been in that role since, I think, 2014. So I was just going to give a brief overview of kind of practical approaches to trauma resuscitation. That starts often with ATLS, which is Advanced Trauma Life Support, which is kind of one of the main classes that is taught here in the States and worldwide, actually, for trauma resuscitation. And we'll review a little bit about the basics of that, the primary and secondary survey, and a little bit about something called vertical versus horizontal resuscitation, which I'll kind of clarify, how we organize a trauma team, and practice patterns. So ATLS actually was born out of what was seen as a need. An orthopedic surgeon back in the 1970s crashed his plane with his family in a field, and his wife was killed and his 3 children were critically injured. And at that time, there was really no organized approach to the care of a trauma patient. He realized it was very haphazard, disorganized, and he kind of decided to change the face of trauma care due to that and help streamline things. So medical, emergency medicine, and nursing groups within Nebraska brought together some guidelines and protocols for trauma patient management. And then this was ultimately adopted by the American College of Surgeons and published as ATLS in 1980, and then ultimately spread worldwide. And it's had several iterations over the last 40 years to where we are today with it. But the goal really is to provide a framework for the management of the injured patient and allow a single doctor in a rural hospital to effectively assess and manage trauma and stabilize patients in order to get them to a place where more definitive care can be provided. The need for a standardized approach was seen because trauma is a leading cause of death in young people, ages 1 to 44, and disabilities exceed deaths even more by a ratio of about 3 to 1. So the trauma-related costs are significant. These are old numbers, but in the US, as much as $400 billion a year. And there can be a significant lack of public awareness for injury prevention strategies as well. Typically, we talk about what's called a trimodal death distribution in trauma. Those immediate deaths that occur right away are patients that essentially bleed to death or have catastrophic injuries at the scene. And then you have late deaths, which are patients that tend to suffer from complications like infection or long-term issues related to, say, spinal cord injuries or things like that. But that group in the middle are the ones where we really try to impact their outcome with something like ATLS. And the general concepts that we look at are addressing the greatest threat to life first. Getting a definitive diagnosis in that time is less important than just sort of stopping immediate issues that can cause someone to die. So it's a physiologic approach where time is of the essence, and the goal is to do no further harm, which includes really not looking for injuries aggressively that are of minimal importance that you can't fix. So the approach with ATLS is essentially circles around the ABCs, which are the most primary things that can cause the patient to die suddenly. So the airway is at the top of the list, managing the airway, making sure that the patient's airway is open and accessible, keeping in mind that there could be a cervical injury that needs to be protected. Breathing then comes second. So making sure that they, if their airway is open, that air can be delivered to the lungs, that their lungs are expanded, that they are breathing. Circulation, stopping bleeding, making sure that any external sources of bleeding are controlled with direct pressure or tourniquets, and assessing for internal bleeding. Disability is D, and that is looking at signs of neurologic deficits, intracranial injuries, or spinal cord injuries. And then E stands for exposure and managing the environment, which includes removing clothing, looking for other injuries that might be hidden, such as gunshot wounds that might be, in places that are difficult to see and they might not be bleeding, and controlling the body temperature to prevent hypothermia. So as far as preparing for ATLS in a hospital system, or sorry, an emergency system that has really a trauma system built into it, the goal is to get the patient to the closest appropriate facility. And that's part of why there are trauma designations for different hospitals. It gives an indication of the types of physiologic issues that can be handled, what types of support are available at that hospital as far as physicians, surgeons, subspecialties. So emergency medical services often have transport guidelines or protocols built in, where if a patient meets a set of specific criteria, they would be transported directly to a trauma center of a certain designation. There's also online medical direction via radio from trauma hospitals with physician support to help in that decision making. And the care then is reviewed systematically to make sure that proper decisions are being made and that patients are triaged appropriately. So as far as triage, it's important to sort patients by the priorities with respect to the ABCs that we talked about and what resources are available at a given institution. And this is often especially utilized in the situation of multiple and mass casualty situations, where we try to disperse patients to many different hospitals in order to offload any one hospital, but try to make sure that patients with severe injuries are triaged to trauma centers if possible. And then more patients that are, for example, the walking wounded, you might transport them to a lower level of care where they might be available to take care of their injuries, but not have resources for more severe injuries. So the primary survey is sort of the first once over of a patient to look for major life-threatening problems. And the priorities are always the same, whether it's an adult, a child, a pregnant female. Always the priorities are to maintain the airway, breathing, and circulation, and to identify those immediately life-threatening injuries. And when we talk about pregnant women, it's important to remember that taking care of the mother and assuring the best physiologic outcome for the mother is usually what determines the best outcome for the baby. So as far as the airway, you want to assess that the airway is open. So you're looking for signs of like gurgling or obstruction to the airway, stridor, or signs that the patient has any narrowing of their airway or an inability to maintain their airway. If they're having like rocking chest wall motion, where they are maybe using accessory muscles to breathe, or there's signs that they're unable to move air efficiently, that would be a sign that you would want to secure the airway. And then patients who have maxillofacial injuries or injuries to their larynx, other neck injuries might be ones where you, even if they initially look okay, would think to early on secure their airway because they might deteriorate. The same thing goes with high spinal cord injuries, where they might have an injury like in the high upper thoracic spine where they're breathing on their own, but the spinal cord injury doesn't allow them to use accessory muscles, where if over time that might become a problem. It's always important when you're assessing the airway to make sure that you maintain the C-spine in a neutral position, because you have not had the opportunity to assess them for C-spine injuries. So you don't want to hyperextend the neck to try to improve air movement through the airway if there might be a C-spine injury. Was I muted? I can't. Am I muted? No, I'm not muted. Okay. Sorry, now I can't see my, okay. They might have this tree branch or, you know, obviously this could be impeding their airway. And in this situation, they also don't know the oropharynx might not be available. So you can see this person is actually nasotracheally intubated. They felt that that was the safest access at that time. And a glaring thing that's missing here is a C-collar. Probably not able to put a C-collar on in this patient because of this injury. So it's important to, when you're manipulating the airway, have somebody holding the spine in place. Sometimes we place like rolled towels on either side of the head and tape them into place, or tape their forehead in a neutral position so that that they're not moving around. As far as establishing the airway, you can always do a chin lift or a jaw thrust. You just, where you're moving the chin anteriorly, you just don't want to hyperextend the neck. You're looking, listening to and feeling that they're moving air, removing particulate matter from their mouth. And then, like we talked about, providing them with a definitive airway if necessary. It's also important to reassess this frequently. Someone with a brain injury might come in and they're maintaining their airway, but if their brain injury progresses while you're proceeding down your evaluation, they might no longer be alert enough to maintain their airway. And then you kind of need to go back to the beginning and start over with your ABCs. You can see here an example of someone who has their head taped in a neutral position on a backboard to keep it in place if you can't have a collar in place. We would then move on to breathing, which is assessing how adequately they're moving air. So you can see if their chest is rising. You're going to listen for breath sounds, sometimes very difficult to hear in a trauma room if there's adequate breath sounds. Their rate, their effort, are they using accessory muscles, looking for pulse oximetry and saturation, and looking for signs of a pneumothorax. So if you have, evidence of a chest injury, maybe there's crepitus on one side of the chest and a fracture, and like rib fractures and diminished breath sounds, and someone is hypoxic, you're probably going to assume that they have a pneumothorax on that side, and you might go ahead and place a chest tube right away in order to restore the chest cavity on that side. So you're looking at their breathing to see if it's adequate and if they're moving air. As far as managing, we can give supplemental oxygen very easily, and then assist with their ventilation if necessary. If we've intubated them and placed an airway, we're going to be ventilating them clearly. If they have diminished breath sounds, signs of blunt chest trauma, there may be concern for a pneumothorax and even a tension pneumothorax. You can proceed with a needle decompression, or if you're comfortable and have the skill set, you could go ahead and place a chest tube straight away. An open pneumothorax is one where there's a wound and air is escaping the lung to the atmosphere. In those situations, you actually want to promote that air escaping. So you would not want to place a completely occlusive dressing. Oftentimes you would tape it on 3 sides and leave one side open for air to escape. Or if you do place an occlusive dressing, then you would need to place a chest tube to act as the means for air to escape the chest cavity. And again, you need to reassess it frequently. Maybe the patient comes in and everything seems okay, and then 3 minutes down the road, they're desaturating, and now they did have breath sounds on one side and now they don't. Well, at any point in time, a small pneumothorax can progress to a tension pneumothorax, and they might need something intervened upon before you've gotten around to diagnosing the problem yet. And then C is for circulation, and that has to do with assessing perfusion. So you're going to assess their level of consciousness, their skin color and turgor, and check for pulses in their extremities and whether or not they're strong, thready. We also typically will place IV lines as part of our circulation assessment so that we have good IV access. And you can assess overall organ perfusion. I think one of the things that's often underestimated as a sign of organ perfusion is mental status changes. So for example, if you have a young patient with severe injury and internal bleeding, oftentimes their blood pressure is normal, but they might be quite tachycardic in order to maintain that blood pressure because they have really good physiologic reserve, but they might be very confused, lethargic, things like that. Those mental status changes are a good indicator that there could be significant blood loss. And then signs of peripheral vasoconstriction, cold and clammy extremities, narrow pulse pressure are all signs of poor perfusion. So as far as managing circulatory issues, especially with respect to external bleeding, the key is to stop any bleeding that you can immediately. So direct pressure, never forget the benefit of direct pressure on external bleeding. This is most effective on the extremities and also at the junctional areas like the groins, axilla, and neck. And then splinting fractures to help prevent ongoing blood loss from major long bone fractures is important, and tourniquets for extremities. Recently, tourniquet use in the civilian setting has greatly increased and shown benefits. It's very unlikely that you're going to cause damage when placing a tourniquet for active external bleeding, and very likely that you might benefit someone. And then when it comes to the neck and the groins and axilla, they're not amenable to tourniquet. Pressure can be beneficial. Then you need to assess for internal bleeding, which is not by holding pressure. You want to obtain large bore IV access. So the key to IV access in this situation is short IVs of a large bore. So like a 14 or a 16 gauge IV, because you can infuse a large volume of fluid rapidly through a large bore IV. IO needles are also very useful if you can't rapidly get a good peripheral IV, and we use those routinely. It's always important to consider upper extremity access when possible in trauma, because if you have a significant intra-abdominal injury and you place an IV in the groin, for example, all of that fluid resuscitation, if there's a venous injury in the abdomen, will just be dumped into the abdominal cavity and not make it up to the heart to be perfused to the rest of the body. And then we initially will give nowadays just 1 liter of fluid. Actually, the original recommendations of ATLS was for 2 liters of fluid, but this is down to 1 liter before we transition to blood products and reassess frequently. If there's a tension pneumothorax, this can be affecting circulation. You would want to decompress that. If there's a large volume hemothorax, the patient is going to need blood products rapidly. You can use ultrasound to assess for signs for pericardial tamponade as well in the setting of blunt chest trauma. D stands for disability or assessing the neurologic standpoint status. So you want to do a baseline Glasgow Coma Scale, which is important. Pupillary response, any localizing signs as far as not moving one side or the other, or like a spinal cord level if there's a suspicion. It's really important to try to at least get a really basic exam before you sedate and paralyze a patient, because otherwise, once you do that, it's really difficult to observe them for neurologic deterioration if you don't know what their baseline was. The Glasgow Coma Scale is 3 separate scores, categories. The highest score is 15 and the lowest score is 3. So someone who's dead will have a GCS of 3. So you first look for eye opening, which has 4 points associated to it with those 4 categories. Then a verbal response, which is a normal conversant patient, all the way down to no verbal response at all. And then a motor response, which is totally normal, follows commands, and then moves all of their extremities, down to just localizes to pain, withdraws to pain, and then actual posturing. So if you tally that up, it at most is 15, and at least is 3. And the best sort of post-resuscitation that the GCS that a patient gets is one of the best indicators about outcome when it comes to neurologic status. So if they come in and their GCS is 4 or 5, and you resuscitate them and several hours later, now they're moving their extremities and maybe following some commands, that's a good indicator of, a positive outcome. If their GCS is 8 or less, it's an indication to secure their airway on arrival and intubate them. As far as exposure, it's really important to prevent hypothermia because it leads to sort of coagulopathy and other hemodynamic issues with ongoing bleeding. And it's also really important to fully expose the patient to look for other injuries that might be missed. This is particularly important in penetrating trauma with gunshot injuries. There might be wounds in places that you don't see. Small caliber injuries can leave very small wounds that if you don't look for them, you won't find them. So always look for physical clues to possible injuries. So obvious long bone deformities, like a large deformed femur or thigh is a sign of a femur fracture. There can be, number one, that indicates a significant kinetic energy injury. And there can be a lot of blood loss associated with a femur fracture. You want to assess for pelvic instability, usually with just very simply bringing the ASIS, gently pushing them together. If they move, then that's a sign of an unstable pelvic fracture. And you would want to be aware of that because that's another source of significant blood loss for a patient. You want to look for hematomas in the perineum because that can be a sign of rectal injuries, bladder injuries, other intestinal injuries, and pelvic fractures. Seatbelt signs are really important to notice. They can be associated with abdominal visceral injuries in children, especially pancreatic and duodenal injuries. And as well, they can be associated with spine injuries if someone has like a sharp flexing of their torso over a seatbelt. You want to look in the ears to look for signs of blood that can be associated. Hemotympanum and raccoonitis are associated with basilar skull fractures. So a lot of different bruises and other signs of injury can give you a clue to things that are going on, which then brings you to the secondary survey, which is a thorough history and physical with a complete head to toe assessment after you do your ABCDs. And then this usually also includes a chest x-ray and a pelvis x-ray as quick places to look for sources of bleeding, which would be into the chest cavity or from a pelvic fracture. If available, you want to obtain what we call the ample history, which are patients' allergies, medications, any past history, their last meal, and then the events or environment of the injury. The secondary survey, you're going to basically do a head to toe examination, looking at all these different organ systems and body areas for signs of injury. This would include a rectal examination and evaluation of the perineum to look for signs of injury. You're going to look in blunt trauma at like signs of blood at the urethral meatus in men, which can indicate a urethral injury, all of those things. So when we talk about trauma resuscitation, there is vertical resuscitation versus horizontal resuscitation. And when we describe all these activities that we do in ATLS, a lot of times you think all of these things are happening in a particular order and down the line. So, obviously this person's horizontal and he's being resuscitated. This person's kind of sitting more upright, but he's not necessarily vertical. So these are all different patterns of injuries, and you have to think about what's going on with the patient at any given time. We have this person sitting upright. Should he be lying flat? But what we really mean by vertical approach is used in the ATLS model when you have really limited personnel and you want to follow these steps step by step to make sure that you don't miss important things. And you have one team leader or physician resuscitator and one nurse, and you're really going to be sequential in doing all of these activities in the primary and secondary survey. So the vertical approach is kind of moving this direction in time. I'm going to assess their airway. I'm going to assess their breathing. I'm going to assess their circulation. And then we're going to get the IVs in and the oxygen and labs sent. And then we're going to do the secondary survey and proceed to definitive care. Horizontal approach is much more efficient and happens in places where we have a much more well-developed trauma team. So in reality, a lot of these things are happening at once. Someone's doing the primary survey and they're assessing the airway and breathing and circulation. And in the meantime, you actually have other people that are putting the patient on oxygen and a monitor and placing IVs and drawing labs and placing a Foley in. And then you'll get your secondary survey kind of in this type of order where much less time is passing because you have more resources. So that's kind of what we mean when we talk about those two different approaches. If you're in a really austere environment and you're the only person around in a critical access hospital, it's going to be a much more vertical approach. When you're in a trauma center where there's more people that show up and a lot of resources, it's going to be much more horizontal approach. And the benefits of the horizontal approach is that you have many simultaneous interventions going on. Every person has their role that they're taking on in that situation and facilitating the care. And the team leader is directing everyone and making sure that all those things get done. But it happens in kind of a controlled chaos way where as little time as possible is spent on that initial resuscitation so that you can get the patient to definitive evaluation or definitive care. So this is a little bit more what that looks like, is you're going to have a scribe nurse on the side writing down the information as someone's at the head of the bed assessing their airway, and then someone else is doing a head to toe examination of the rest of the body. And then someone else is placing the IVs and drawing the labs. This is a quote from a trauma surgeon. Trauma resuscitation is a team sport with high stakes. If the team loses, the patient dies. And so it really is important, that we work as a team and we practice working as a team. And that's something that we try to do here, is run simulations in our simulation center so that people get used to working with each other and understand what the plan is. It's always important to have a clear mission when it comes to taking care of a patient that's injured in this way, and a defined strategic plan. The roles need to be well defined and ideally assigned before patient arrives. So if you get 5 minutes of extra notice that a patient's coming, you know, the team leader can look at everybody and look at them by name and say, you're doing this job, you're doing this job, you're doing this job. And then you really have to trust that you have to trust that the other people in the room know what they're doing and are going to do their job. Because if you're duplicating labor, then you're not, you know, necessarily getting the best outcome for the patient. So really preparation, anticipating what might be coming, pre-assigning those roles and procedures if necessary. So I will look at the residents and say, I will look at the message that we receive for what's coming in, and in my mind be thinking, okay, these are the possible injuries that we might be dealing with. So I'll say to one of the residents, I want you to have the chest tube tray ready, and you need to be prepared to put a chest tube in, or you need to be prepared to put a line in the patient or an IO, and who's doing the airway, and making sure everyone's in their proper position, and then that roles are assigned. And usually we set the room up in a specific way where each of these people is standing at the bedside or off to the side where they are the most effective and least kind of in the way. So that's what we talk about with respect to this horizontal approach. And the ATLS model kind of gives us the framework for doing those things. The real goal of ATLS is to teach the provider in more remote settings and critical access settings what they can do to stabilize a patient. So to look for major sources of bleeding, rule them out, provide stabilization such as a decompression of the chest or a pelvic binder in the setting of a pelvic fracture, and establish IV access or establish an airway. And then if that's the limit of their capabilities at that place, they can stabilize the patient and move them on. If they're not going to be managing a head injury and they don't have a neurosurgeon on site, it's probably not useful for them to get a bunch of imaging of the head. If the patient shows signs of intracranial hypertension, we might treat the patient for that with hypertonic saline or some sort of hyperosmolar therapy, and then move the patient on to definitive care. So spending a lot of time in imaging at hospitals where they don't have the resources to care for the findings is typically not recommended unless there's going to be a delay for some reason in transferring the patient. So ATLS gives us that framework and sets us up for these primary and secondary surveys. It kind of shows you this vertical approach, but then we adapt it in a more horizontal way when we have more resources. And that's what an organized trauma team does. So it really gives us a framework for rapid identification of life-threatening injuries and getting someone to definitive care. And that's all I had. It was a little shorter than I thought, sorry. Does anyone have questions? That was muted.
Thank you, Doctor, for your lecture.
Okay. Alicia, thank you. I think everybody was muted by the admin, and that's why nobody could answer. But while everybody's gathering their thoughts, I want to thank you for giving the lecture, and it was outstanding. It was refreshing even for me. Just want to also introduce on the call is another colleague of mine, Alicia Kieninger A. She's a gynecologist in the Phoenix area, and she helped me organize this effort to bring these lectures. So thank you, Alicia, for joining if you're on the call. I'm just going to talk in Arabic. بالنسبة للأخوان المشاركين إذا عندهم أي سؤال ويشوفون صعوبة بالإنجليزي ممكن يوجهوه بالعربي وأنا أترجمه، وإذا عندكم بالإنجليزي تفضلوا وسألوا الأسئلة. So if anybody has a question, go ahead. All right. Looks like everybody is happy with the lecture. حيدر, do you اكو حد عنده اسئله من يمك كاتبيه او بالشات لانه ما دا اشوف اي شيء.
لا ما كاتبين اي سؤال.
اوكي.
دكاترة إذا عندكم سؤال تفضلوا. أنا انطيت يعني سماح للصوت، اللي يريد يتكلم يفتح عن ميوت ويتكلم.
Okay. All right. Well, Alicia, I don't think anybody has any questions. So thank you very much
No
for
problem.
everything that you've done. I
Thanks for
appreciate it.
having me.
Okay. حيدر عندهم أي شيء إذا يحبون، لأنه هاي أول محاضرة، إذا عندهم
إذا
أي
عندكم
سؤال
شباب
أو
إضافة أو سؤال.
لأنه المحاضرة انتهت، هاي فرصتكم، اللي عنده أي سؤال إذا يعني يقدرون همين يقولون إذا عجبكم الموضوع، إذا كان أكثر متقدم مما توقعتوه، جدا بسيط، إذا مواضيع أخرى للمستقبل اللي موجودين من الحضور ممكن يشاركونا.
يعني طبعا I can second Dr. Firas. Thank you so much for bringing the doctor. It was like a beautiful presentation. عاشت إيدكم. But the question really what we need to know إنه للحضور كلهم عندكم أي سؤال؟ شلون تريدون الفيوتشر lectures تكون؟ هل هو هذا الشيء اللي أنتم تريدوه من الموجودين برا؟ تساعدنا إنه يعني نعرف شنو شلون نقدر نساعد in a better way.
اللي كان يتكلم طبعا دكتور علياء، مثل ما قلت لكم، هي زميلتي طبيبة نسائية في أريزونا. الحقيقة نريد نسمع من عندكم. أدري يجوز الحضور أما خجلانين أو ما يريدون يحكون، بس رجاء نريد نسمع من عندكم أي موضوع تحبوه. هل هي متعلقة بالجراحة؟ اللي سمعناه من يعني الجهات المنظمة لهالمؤتمر إنه كانوا تركيز على التراما والإسعاف والطوارئ. إذا هذا تريدون نستمر نقدر نستمر. هاي المحاضرات هي لكم مو لنا، وقد ما تنطونا يعني ملاحظات عن المحاضرات اللي تريدوها نقدر نوجهها بالطريقة اللي أنتم تساعدون. فرجاء إذا عندكم، حتى لو إذا عجبتكم ممكن تقولون إنه كل الزينة، وإذا تريدون تغيرون كملوا. تفضل.
مساء الخير دكتور.
أهلا وسهلا.
Thank you very much for this nice presentation. أنا رامي رمضان، مدرس في كلية تمريض جامعة الموصل في العراق.
أهلا وسهلا.
أهلا وسهلا. I have a question about the emergency drug maybe allowed in ambulance before or arrival the patient to the hospital. يعني أسأل إنه هل هناك معايير محددة لاستعمال الأدوية الطوارئ قبل وصول الجريح أو المصاب إلى ردهات الإمرجنسي في الهوسبيتال؟ تختلف from country to country such as adrenaline or atropine. Thank you.
ما يخالف. طبعا الدكتورة تركت، هي الدكتورة كينينجر تركت المحاضر لأنه يعني أمانة ماكو أسئلة، بس أنا أقدر أقول لك من خبرتي أكو هنا النظام الطوارئ ونظام الإسعاف ويتبع 3 أنواع من الطوارئ. هذا في أمريكا طبعا دا أحكي لك. أكو سيارات الإسعاف اللي هي فقط لأجل النقل، اللي هي يعني ما مجهزة بأي أدوية، ما مجهزة بأي أجهزة يعني التنفس الصناعي أو الإنعاش. هذول ما عندهم أي حق ينطون أي أدوية. أكو الخطوة الثانية اللي يسموها يعني AMS، اللي هذول عندهم فقط أدوية معينة يقدرون ينطوها تحت توجيه الطبيب. هذول الأدوية المعينة هي فقط الأدوية يعني الناركوتكس يعني للألم، وأحيانا إذا أكو أدوية مثلا الأتروبين ممكن ينطوا إذا أكو النبض يقل. في حالة إنه أكو أكثر من هذا، النظام الطوارئ في أمريكا يسموه ديسباتش، من يخابرون ال 911 يحاولون يقدرون ياخذون أكثر معلومات ممكنة. إذا نوعية الحالة تستوجب أكثر من يعني فقط النقل، فالسيارات الإسعاف اللي تجي يسموها Advanced Life Support ALS Support. هذول السيارات الإسعاف مجهزة بفنتليتر، مجهزة بالسي بي ار، مجهزة بالإندوتراكيال intubation، وكذلك عندهم يتبعون كل الأدوية اللي موجودة بالادفانسد لايف سبورت او ادفانسد كاردياك لايف سبورت، مثل اللي ذكرتها، من الاتروبين، من الادرينالين، من الابنفرين، من الاميودرون، من الادينوسين. كل هذه اللي موجوده عندنا النظام الاي سي ال اس، هذول ينطوها حتى من دون الرجوع الى يعني طبيب، واثناء النقل اذا يحتاجون ينطون اي جرعه اخرى ممكن يتصلون بطبيب الطوارئ وممكن انه يوجههم. فما اعرف اذا جاوبت على سؤالك، بس الحقيقه يعتمد على نوع وبنفس الوقت الاشخاص اللي هم يعني الكادر التمريضي، خلينا نقول، اللي يسوقون او يجون بهذول الاسعاف عندهم درجات معينه وتدريب اكثر. يعني ابو الاي ام تي ما يقدر ينطي سي ال اس وكذلك.
شكرا جزيلا دكتور، اكيد وصل الجواب. يعني هو هنا الموضوع موضوع comparison يعني between countries. احنا العراق لا يوجد permission مثلا لسياره الاسعاف انه for nurses انه يعطون الامرجنسي دراجز اثناء نقل المريض الى المستشفى. ربما هذا يكون محصور في exclusive for physician give this drugs يعني exclusive. فهنا اكو فرق، فقد نفقد بعض المصابين، تحصل حالات وفاة، توقف القلب cardiac arrest before arrive the patient in the emergency in the hospitals. Okay, thank you very much دكتور.
يا اهلا وسهلا. اي سؤال اخر او اي راي حول يعني طبيعه المحاضرات بالمستقبل؟
أنا شفت one comment مكتوبة إنه لو تكون الكلام أبطأ، so هاي سهلة، ممكن ندبرها next time.
الحقيقة طبعا محاضر عن محاضر يختلف، والطبيبة اللي قدم المحاضرة هي أمريكية يعني ولادة وكل هنا، فما عندها أي باك جراوند. اللغة راح تكون يعني أعرف إنه يجوز مشكلة، بس الحقيقة نحاول إنه بقدر الإمكان إحنا نكون موجودين، يعني تسهيل التواصل بين المجموعتين. أي ملاحظة أخرى؟ أي موضوع آخر الناس اللي تحب تسمع؟ شنو الموضوع اللي تريدوه؟ أنا الحقيقة أقول لك الموجود عندي حاليا، يعني الشخص الثاني اللي راح يتكلم هو راح تكون كذلك طبيبة، هي أمريكية، مسؤولة قسم جراحة الثدي عندنا بالمستشفى، والمحاضرة راح تكون عن البروتوكولز حول تشخيص يعني سرطان الثدي، انواع التداخلات الجراحيه، وكيف استكشاف يعني اقارب المريض او التحليلات الجينيه، وكذلك انه شنو يعني اوتلاين من الكيموثيرابي واللونج تيرم ثيرابي. فاذا هذا يكون يناسبكم ممكن ارتبها يعني المحاضرة الثانية. إذا أكو أي آراء ثانية رجاء أعطونا إياها.
موضوع جدا مهم دكتور، خاصة هسه منتشر عندنا بالعراق مسألة الكانسرز. حاجة ايديكم، وانا هم راح اسوي استبيان على المواضيع اللي يحبون الدكاترة يعني تلقاها بالمنصة عندنا، ونشوف شنو اللي أكثر يردوه أنطيكم علم به.
أي شيء آخر إحنا بخدمتكم، لأنه هالمحاضرة لكم، فشقد ما نسمع من عندكم شقد ما راح تكون أكثر يعني مفيدة للكل.
طالبين مانجمنت اوف جي اي بليدنج. انا الصراحه انا تكلمت مع دكتورين هنا في فينيكس واثنيناتهم كلش انترستد انه ينطوكم محاضرات، عندهم بس كولات زياده هالفتره الاسبوعين الجايه، فانطوهم مجال في اسبوعين 3 وان شاء الله يكونون على الليست الجايه. اثنين من عندهم نعم
تمام دكتورة. اي هو الوقت صح شوية حرج، بس عادي احنا نرتب اي وقت. عادة احنا الجمعة او السبت هيك وقت مساء كلش مناسب، يمكن لنا ولكم.
نعم اي. او بالنسبه للنسائيه انا قلت ابلش، شفت انه اكو طلب على البري كلامسيا يعني كلامسيا، سو قلت انه نبلش بهالموضوع.
تمام.
دكتور عليا، زملائك اي موضوع راح يقدمون؟
زينة هي طبعا أنا خليتهم يعني سويت لهم introduction ويا زينة. اثنين من عندهم اثنين من عندهم هم راح يحطون يعني هم جي اي، انا راح يحكون على الجي اي بليد مانجمنت. ودكتور جنرال سيرجن بميشيغان تكلمت وياه، هو كان كلش انترستد انه يتكلم على التروما ان ريسستيشن. بعد ما اعرف شنو صار من عند دكتور مصطفى، ما اعرف. هي زينه يعني بعد على اتصال وياهم. انا اكو دكتور طوارئ في استراليا اتصلت بي and he is willing انه يشكل همينه، فما اعرف. I think زينه عندها الاخبار انه شلون الريسبونس او التجاوب وياها. ما اعرف زينه اذا تريدين تعلقين شويه.
هو زينه ويانا المفروض يعني تسمعنا.
مشكلة.
بس هو اللي يساعدنا اذا انتم تقدرون يعني تعطونا مثل ما يقولون فيدباك او.
الو زينه.
ايه دكتور، هلا دكتور، شلونك؟ شكرا جزيلا دكتور علي. دا انتظر يحضر لي سكجول كل شيء اللي خاص بالامرجنسي، ويدز لي المواد ان شاء الله، ونحضر الجدول شلون راح تكون حلقات المحاضره. حاليا لحد هسه انه بس انه قال بس مشغول شويه، يخلص اللي عنده ويدز لي كامل المحاضرات والاوقات اللي يقدر بيها والايام.
تمام، عاشت ايدك.
طيب، إذا الأخوة والأخوات ما عندهم أي تعقيب آخر، إحنا نشكركم وإن شاء الله تكونوا بخير وإلى لقاء قريب.
كلش تشكرك دكتور على جهودك، ممنونين منك.
شكرا دكتور، لا شكرا جزيلا. ان شاء الله احنا قبل كل محاضره دكتور بدنا نسوي سيرفي، نسال اي المواد المطلوبه، المحاضرات المهمه اللي حابين تكون موجوده، فان شاء الله اوافيكم اول باول.
شكرا عزيزتي، وان شاء الله بس خلينا نتواصل انا ودكتور عليا وياكم. وانا هسه بس ان شاء الله يمكن بعد اسبوعين راح تكون المحاضره الثانيه ونعطيك الخبر بالنسبه لسرطان الثدي.
تمام، عاش ايدك دكتور.
يلا عيني، مع السلامه.
تصبحون على خير. مع السلامه.
باي باي.